Well, welcome everyone. Welcome to the, I believe it's 9th annual Robert J. GORLIN Lecture. As many of you know, Bob's picture was showing just a little bit earlier, was one of our most eminent professors here at the university and in our department, a Regents Professor, one of the most published and well-known geneticists in the world, actually. We had a great dinner last night with our speaker for today down at the Nickel Island Inn, and we had a chance to talk about Bob as well as some science. Kathy GORLIN, his daughter, attended, as well as some people who are traveling about, like Elsa Shapiro and her husband Vic Bloomfield came back last night, and a good number of our pediatric nephrologists were able to make it too. And that allows me to segue to talk briefly about our speaker, Dr. Paul Grimm from the Stanford University Medical Center. Professor Grimm has really focused a lot of his career and research on pediatric transplant and related conditions. And one of the key things that he's taught us or is teaching us, and one of the special reasons we wanted to have him come and talk as our 9th annual Robert J. GORLIN Lecture, is because of his interest in a genetic condition known as cystinosis. Now, when we think about lysosomal diseases here at Minnesota, we often think about Hurler syndrome and Sanfilippo syndrome and things like that, Fabry disease that Bob Desnick pioneered. But cystinosis actually is one of the first diseases for which there is a pharmacologic therapy, and I think that'll probably come into to Dr. Grimm's presentation. So without further ado, Paul, thank you for coming to talk with us today, and Dr. Paul Grimm from Stanford University.
Thank you very much, Chet. It's really an honor to be invited to give this talk, and I learned a lot about Dr. GORLIN last night at dinner. You know, what a person who was so interested in every aspect of life and was always asking people questions and was humble, and it was really cool to hear about. Also, I'm happy to be here because the reason I'm a nephrologist was because one of the trainees that trained here in the 70s, John Crocker, was the nephrologist where I was a pediatric resident in Halifax. And he was the one that really stimulated my interest in nephrology, so it's kind of like coming back, and it's kind of cool to be here. So I do mostly kidney transplant, but I've developed this sideline of looking after patients with cystinosis. There we go. And I started seeing just an occasional patient with cystinosis, but then I got involved with the Cystinosis Advocacy people. One of my patients was really active in running and organizing an organization for parents and families with cystinosis, and they got me to go to one of their meetings once to give a little talk, and then I went to another one, and then the patients thought I was interested in cystinosis, although I didn't know much more than anybody else, and so they started coming to the clinic once in a while, and so it just built from there, and now I actually know about cystinosis. And we see a fair percentage, we have about 80 patients, and since there's only about 500 that have been diagnosed in the U.S., it's a fairly substantial. Okay, so I know there's pediatric residents in the audience and students, so a lot of the talk is sort of focusing on you. The lysosome is a recycling plant, and it gets proteins which are worn out and then breaks it down to constituent amino acids, for example, and then releases those amino acids to allow the cell to use them again. And just imagine if you were running a recycling plant, here's the paper being shipped out to be reused. But what happens if there's a strike? The administration of the lysosome or the recycling plant is still taking deliveries, but the paper truckers who take the paper out aren't showing up. So for a while there, you just stack the paper neatly, but then after a while it gets a little bit crazy, and then later on it gets to the point where this stuff is preventing the normal function and the normal activity and the normal machinery, leads to disaster. So if you have that picture of lysosomal storage disease, cystinosis, I think that's pretty accurate. So the cartoon biology, here we have a lysosome, and there's the amino acid cysteine, and there's the transporter which pumps the cysteine out so the cell can use it, and that's called cystinosin. And cystinosin transports cysteine out of the lysosomes like this little diagram. And in patients who have cystinosis, they have a defect in this protein, this gene. So either defective function or absence leads to a buildup of cysteine because they can't get it out of the lysosome. And you get all these crystals, leading to precipitation. So the crystals actually perforate the lysosomes, causing the lysosome to spill its digestive material into the cell, killing the cell, and then developing precipitates of the crystals in kidney, bone marrow, liver, brain. It's truly a multi-system disease. This is the cartoon of the protein. So like so many others, it's a 7-transmembrane region protein. This is the inside of the lysosome. This is the outside of the lysosome. And all these colored dots are amino acids where there's an abnormality that's been identified in cystinosis. So there's over 100 different mutations of this gene that are known. However, about half of the Caucasians that you'll see with cystinosis have this deletion right here, which leads to total non-function of the protein. Now, currently, the estimate is that there's 1 in 100,000 to 1 in 200,000 live births. They've identified 400 people in the U.S., but we find more each day. Now, that doesn't seem like a very large number, but you have to remember that until recently they all died by the time they hit teenage years. And in many parts of the world, they still don't get care. But as understanding of this disease expands, this population is really increasing, and we know there's many more patients in the U.S. than when this slide was made. 95% of the patients have an infantile or early childhood onset. Your typical North American child has blonde hair. But if they come from a Hispanic or African American race, they do not have blonde hair. They look like their racial colleagues. Untreated, they live about 10 years, and what kills them is kidney failure. But since we developed the ability to keep children alive with dialysis and transplant, a whole new generation of people have emerged, and they can live well into their 50s. So this is a picture taken at one of the family conferences, and all these children have cystinosis, and I wanted to point out the high prevalence of sunglasses, because cystinosis is a disease which affects the cornea. The cornea get packed with crystals which diffract light, and sunlight hurts them. So the kids, especially if they're not tolerating or taking their medication, they have sunglasses. As you see, this is a Filipino girl, nice dark hair, but we have a lot of blondies, that's for sure. And people of Asian, and not in this picture, but we have African American as well. So until recently, we knew that in the first year of life, you got Fanconi syndrome. The proximal tubule of the kidney was damaged. And then as they lived into sort of school age, they developed hypothyroidism and photophobia, and then they would pass away of chronic renal failure, mostly by the time they were 10 years old. But when we developed the ability to look after children with kidney failure, we realized that it was truly a multi-system disease, because in the late teens and early adulthood, they would develop myopathy and difficulty swallowing and speaking, blindness, diabetes. We found that the male testicles did not function, and many of them developed pulmonary dysfunction, not because their lungs were involved, but because they were so weak they couldn't breathe or cough, and CNS issues. This is an amazing slide. So just imagine someone getting a kidney from a child who's passed away and microdissecting the glomerulus and the proximal tubule and distal tubule of a normal nephron. This is a slide of a child died of cystinosis at age 1.5. And the microdissection shows there's nothing left of the proximal tubule. All the cells are gone, and all you see is the membrane, just a shadow. So the proximal tubule is hit really hard, and especially for people doing pediatrics, the next thing is typical board exam questions. Proximal tubular damage causes the renal Fanconi syndrome. The proximal tubule is supposed to reabsorb lots of small molecules that are filtered freely. If you don't have proximal tubular function, if you have Fanconi's, you have polyuria because of all the electrolytes you lose, amino aciduria, sugar in your urine, phosphate losses, bicarbonate losses causing severe renal tubular acidosis, low molecular weight proteinuria, calcium in the urine, and a very low uric acid in the blood because it's leaking. But the reality, when you're taking your boards, is one of the most common questions is the list of heritable disorders that cause Fanconi syndrome, and the fact that the most common inherited condition and a treatable condition is cystinosis. But then if you can follow it up by all these other conditions which you may want to read about. As opposed to heritable disorders, the acquired disorders you may see regularly as a pediatric resident or in the hospital, drugs do it. The cancer drugs, epilepsy drugs, antivirals, some of our antibiotics, and toxins. Before I went into pediatrics, I was a rural family doctor in northern Saskatchewan, and I saw a lot of proximal damage due to glue sniffing. Because the people living on the native Indian reservations were unable to afford alcohol or other drugs of abuse, glue was a cheap way to get high, and the toluene caused acquired Fanconi's. Okay, children don't come into your ER with a diagnosis of Fanconi syndrome. They come in complaining of polyuria. They pee all the time and they get dehydrated. And most of the children I see will tell you the story that it took 6 months to figure that out. The child started peeing more and being irritable, and the child maybe even had a few hospitalizations for dehydration with a mild gastro. They were discharged and they came right back. The children pee huge amounts of urine, and often the mother realizes before anybody else that they're a year old. They give them a bottle of formula and the child throws the bottle away. They give them a bottle of water and the child just sucks it down. And so by the time it's diagnosed by healthcare providers, they're usually 14 or 16 months old and they're falling off the growth charts. So families, when they get together, they don't talk about polyuria. Because it's such a big deal, they talk about it as serious urination issues. But humor aside, polyuria causes sleep problems. It affects socialization because they're unable to have sleepovers. School issues, they're peeing every hour. And as they get to figure out how to do the potty dance and delay urination, well, they can develop big bladders, which can actually lead to secondary renal damage. So diagnosis of cystinosis. Cystinosis is a rare disease, but as a pediatrician, you're going to see rare diseases, and you need to try and be able to identify the patient with that rare disease amongst the regular patients that you're seeing all the time. Children with cystinosis tend to be diagnosed with sometimes even Bartter syndrome because they vomit so much they're alkalotic, or diabetes. Because they're spilling sugar in their urine because their proximal tubule doesn't work, they've got a positive urine dipstick for sugar. So they got polyuria, positive urine dipstick for sugar. They may actually get put on insulin or get referred to a diabetes clinic. They may get a diagnosis of nephrogenic DI because they're so polyuric. Or they may show up with rickets because of the acidosis or just plain old failure to thrive. But it takes a clinician who's thinking a little bit and just being interested in listening to the family and realizing that they're telling a story that sounds like medical issues, and then you figure it out. But the history is failure to thrive, growth retardation, vomiting, constipation because they're so dehydrated, rickets. If it's a European, if they're pale and fair complected, that might give it away. Making the diagnosis, the number one way to make the diagnosis is a blood test, which measures the cysteine in polymorphonuclear leukocytes. Because PMNs are loaded with lysosomes, the blood sample is prepared to pull out the PMNs, and then you can measure the cysteine in the lysosomes to make the diagnosis. Another way to do it is by an eye exam, by finding the corneal crystals. Very few people in the US have genetic testing, but it's very common in Europe and in other parts of the world. So this is an example of the results of cysteine testing in normals, in affected patients off therapy or on therapy, and in heterozygous controls, so in the parents. So there's a clear distinction between normal, heterozygous carriers and people who are affected. By the time they're about a year and a half, they should have crystals. So this is a slit lamp exam. So normally when you do a slit lamp, an ophthalmologist does a slit lamp, the cornea is crystal clear. But you can see this cornea is full of these crystals, and it reflects sunlight. So sunlight hurts. So they squint, they avoid the sunlight, they cry a lot, and many of these kids show up to their doctor at age 3 or 4 wearing their sunglasses in the office. But you can't rely on the presence of crystals to rule in or rule out that diagnosis. So this is just age in years, and this is a rough score of corneal crystals. And there's a variety of numbers from very high amount of crystals to fairly low amount of crystals. So You may have a 1.5-year-old or even a 2-year-old who has few crystals. And if you've ever tried to examine the eye of a 2-year-old, it's not easy. So I have great sympathy for ophthalmologists. Unless you're doing an examination under anesthesia, crystals may be missed. And I have patients where they saw an eye doctor, the eye doctor didn't see crystals, and so they stopped thinking about cystinosis for 6 months or even a year. And then it turned out the kid actually had cystinosis, and this is such a common picture. Okay, rickets. So rickets have many causes. Vitamin D deficiency is certainly very common, and the more north you get, the more covered up people are, the more their diet is poor, rickets are more likely. But rickets can also be due to rare diseases. And so this is the classic cupping of the metaphysis, bad bone remodeling, fractures, delayed bone age. And when your acidotic, when your bicarbonate levels are low, and when your phosphate levels are low, the bone is used as a source of buffer and calcium and phosphate to keep your cells functioning, and your bones melt away. So I love this picture, and this is what I think of when I think of people who are chronically acidotic or have rickets. So when kids got their organ transplants, or we figured out how to dialyze them, we found out that there was a whole other set of disease which came out. People in their teens who did not get therapy directed at the disease develop a distal myopathy. They can't open jars to start with. And notice the depression here. This is the most easy place to find the muscle weakness, is that interosseous space. The normal muscle, which is nice and bulky, especially if someone plays guitar or something like that, is just gone. But as time goes on, they can develop calcifications in the brain, and the myopathy can spread. So I don't understand this, but I'm told this is a swallowing image showing that the person is continually aspirating clear liquids. This shows the deficiency of muscle in the supra and infraspinatus, and he's got no deltoids. So people like this in their 30s come to my clinic, and to shake hands with me, they go like this. Because they have nothing. They can't brush their hair, they can't raise their arms, they have difficulty getting out of chairs, so classic proximal muscular weakness. And they may have retinopathy. So it turned out that adults who used to live, well, people who used to live to adulthood before we had a specific treatment, most of them died of aspiration and sudden death because they couldn't control their secretions and they couldn't cough. Well, now there's a specific treatment. Renal transplantation prolongs their life, no doubt about it. And the nice thing about putting in a kidney is the disease does not come back in the transplanted organ. So that's good. And graft survival in patients with cystinosis is actually better than age-matched controls for reasons we don't quite understand. But what really made a difference was cysteine depleting therapy. So going back to in the 1970s, a guy named Jerry Schneider and his colleagues Jess Toney, working with NIH funding and working in San Diego, were playing around with drugs that they bought from a drug company, a chemical company, Sigma. And they found that if you took a chemical called cysteamine and threw it into culture, and then they gave it to patients, they didn't actually have to do much FDA or IRB stuff. That was all in the good old days. Cysteamine could be absorbed in the intestine, get into the blood, get into the cells, get into the lysosome, and bind cysteine. And then it would trick the lysine transporter to pump the stuff out of the cell. And so that was, how the thing worked. So, okay, cool. So then by pumping, using the lysine transporter to pump cysteine out, you could deplete the cells of the cysteine in the lysosome. And it worked. So in Canada, as a pediatric resident in the 80s, these guys were shipping cysteamine all over the place. So even in Canada, we had a patient in this study. But it was officially approved by the Food and Drug Administration in 1994. Great, everything should be rosy. And it really works. It doesn't work in the cornea because the cornea doesn't have blood supply, so you have to give drops every hour. But this is the same cornea before starting treatment and a year after starting treatment, completely depleting the corneas in people who are compliant. And that's the big issue. So, and cysteamine therapy delayed kidney damage. So this is patient age down here, and this is GFR here, okay? So in patients who got no treatment, they were all dead or on dialysis by the time they were 10 years old, pretty much. Patients who got started on cysteamine therapy, partially not very adherent, or maybe later in life. Oh, damn, I'm doing that backwards. There we go. Their GFRs were better, and so the progression was delayed. But the patients who had really good treatment had the best outcomes, and you can see here their GFRs are maintained well into their late teens. So cysteamine therapy works. However, most of the patients get so much damage in the first year of life before they're diagnosed that kidney failure is inevitable sooner or later. So in my clinic, we plot 1/, serum creatinine graphs and GFR graphs, and we often find that we can predict when they're going to need dialysis or transplant. So this guy, as a school-age kid, was doing well. Here he is. GFR in about 50, and then he hit puberty, and it was a downhill course to getting a successful transplant. Now, he was diagnosed about a year and a half. Now, this is a story not so typical. This was a girl who was diagnosed at 8 months. Her parents were paranoid, and she was adopted. And they, when you don't know about an adopted kid, your radar's up. And so they kept bringing the kid back to the doctor. There's something wrong. There's something wrong. Ultimately, she was diagnosed at 8 months. And she also was lucky she was able to tolerate cysteamine. Her father was an ex-Marine, so they never missed a goddamn dose. And that's how he would tell you. So her GFR is maintained 55, and she just graduated from USC with a master's in social work. So she's never going to need dialysis. So early diagnosis makes a difference, as does taking enough to maintain good white cell cysteine levels. But here's the problem: as much as humanly possible. I have one other case family series. So these are patients of mine, and you can tell they're 3 sisters. You can guess which ones have cystinosis and which one doesn't, just by the color of their hair. The first daughter, diagnosed a year and a half. Now, her parents are Mennonites, and you have Mennonites here. So they believe that if God gives you a task, if you have a job, you do it. So this girl probably never missed more than a couple doses in her life. And at age 22, her GFR is around 45. No dialysis, no transplant, and she's doing well. And she is a recreational therapist in a nursing home right now after college. She had a little sister who was born after the diagnosis of big sister. She was identified to have cystinosis by the blood test and started on cysteamine before she was a month old. At age 19, her GFR is barely reduced. She's got some Fanconi's, but she'll probably never have the need for dialysis and transplant with good therapy and early diagnosis. But look at the growth. So this is big sister, or I should probably call her older sister. So she was well below the 3rd percentile at diagnosis, coasting along. This bump is growth hormone, and she just made it to the normal percentiles. Little sister, or should I say younger sister, this is her therapy. This is her growth, no growth hormone. She's now about 75th percentile. She's tall and healthy looking. Again, which you can get with early diagnosis and therapy. And this is the family, to just point it out. This is affected first child, and this is the height of the affected second child. This is the unaffected third child, and both parents are obligate heterozygotes, and so you can see the hair coloring and also their height. And this is the unaffected fourth child. We do not have the white cell cysteine back on this one. We know that early therapy and good therapy affects better neurological outcomes. So this is work by Doris Trauner at UC San Diego. These are a bunch of different subscales of neuropsych testing. Blue is normal people. This is people who were diagnosed later, and this is people who were this is people who were diagnosed later. This is people who were diagnosed earlier. So there's better outcomes across the board with earlier diagnosis and therapy, and the p-values are all statistically significant. And if you take your pills, the muscle deterioration pretty much stops. So we know that the therapy works in most of the major issues in cystinosis. But the same person who developed this therapy wrote this about 10 years after FDA approval. Simple in principle, just take your medicines, but difficult in practice. We have huge problems with poor adherence. The cystagon, the cysteamine, requires every 6-hour dosing for it to be successful, leading to sleep disruption in the children and the parents. You have to wake them up. Oral cysteamine is painful. Cysteine is used in stomach ulcer research because it reliably causes stomach ulcers in dogs and many other laboratory animals. So they give cysteine to the dogs, they get a stomach ulcer, and you can test drugs on them. So we're giving this to our children, and it hurts. Each dose hurts. And cysteine is metabolized to dimethyl sulfide, so they smell like rotten eggs. So these children and adults who take it have bad body odor and halitosis. And they tell me stories of being completely shunned in school, being told you can't work with customers when they have a job because they complain about your hygiene. You need to take it every 6 hours. If you take it every 6 hours, your white cells stay below the threshold. If you go to every 8 hours or TID or QID during the day, that nighttime period, you're way above the threshold and you develop apoptosis of your cells. And patients who took the drug 3 times a day did not salvage their kidney or other organs like people who take it religiously. So to be successful with this therapy, the kids and the parents really need to have courage. They need to be able to take a drug that makes them smell. They need to be able to take a drug that makes them hurt. Now, half of my patients are over 21. I'm a pediatrician, but they have nowhere else to go, so they come to the clinic because we can at least talk about these things. So I've been forced to sort of look after patients. My oldest is 50, so we were just talking about looking after adult patients in the context of a children's hospital earlier. And there's a huge variety of outcomes. I have some patients who are in a wheelchair, blind, totally dependent because of severe muscle weakness. I have other patients. I got a 46-year-old minister who mows his own lawn, a 33-year-old emergency medical tech who works in Portland throwing around drunks in an ER. I have a 40-year-old engineer who works for Boeing. So what makes these guys different than these guys? They will all tell you. Their parents could be described as Nazis. You will not miss a dose of your medication. This EMT tells me the story. He wanted to go to Boy Scout camp and not smell. To have 1 week in his life where he could be a normal kid. So he left his cysteine. They're in the bus, and he hears a car beeping, honking, honking, honking. They look out the window. Shit. There are his parents chasing the bus. They are not going to let him miss his medications. And now he's really grateful. He's married, got a wife. He's thinking of going to PA school. He's got a future. So anyway, some patients are just lucky. They're the second child in a family with cystinosis, so cysteine treatment was started early. And they're lucky because they can tolerate it. And their family, there's 2 parents. They're not undocumented workers working 18 hours a day trying to survive. So there's someone at home to give them all 4 doses, exactly every 6 hours, each and every day. When they hit teens, they're not too rebellious, or they have really good personal sort of self-confidence to say, if my friends don't love me for who I am, even though I stink, they're not good enough to be my friends. Some teenagers say that, but not many. So I hate when my therapy depends on luck, but unfortunately in many aspects that's the way it is. So there's a new drug which has been FDA approved now for about 2-3 years. In the news, you hear about it because it's so much more expensive than the originator, but that's the way it is in the orphan disease world. So ProCysB, or delayed-release cysteine, they started off with research that was funded by advocacy. So this was the family groups that got together, got some money together, and funded a GI doc to look at alternate ways to give cysteine therapy. And that research showed that if you give it into the intestine with a tube, it doesn't hurt, and it's absorbed just as well. So they did also through advocacy, the first work which they got it to be enteric coated with a chemical that resisted acid, and so it wouldn't be released until it hit the small bowel. And the preliminary work looked good, and so then they licensed it. They turned over the patent to Raptor, and Raptor successfully brought it to market, and it's now FDA approved in a bunch of countries, and it makes a huge difference. And the beads are various sizes, so they have a delayed release property, so you can give it twice a day, and it doesn't hurt if taken right. And, you know, this is the peak blood level when you take the short-acting drug. This is the peak when you take the long-acting drug. This is white cell depletion, and what it shows is basically you can get away with twice daily dosing, which is huge. Most patients have markedly fewer GI side effects. Little kids, markedly improved feeding, reduced need for tube feeds. And we had patients coming from across the country monthly for a while, and then every 3 months for 3 years. We only had 1 out of the 45 patients who quit because they thought there was so much benefit to be in this study, and they didn't want to stop it until it got FDA approved. And this is an example of 2 of my patients in the same family. And this guy's actually got a weight problem. He's eating so well. So the 2-year follow-up showed that you could markedly improve quality of life with this experimental drug. And in various aspects of emotional, physical, school function, it was all better than the controls. And this was published in Journal of Pediatrics. There are some studies where we would have them blow into these metal balloons, the metal party balloons, and send them off to measure exhaled dimethyl sulfide. And there seemed to be less halitosis in the study drug group than in the immediate release group, probably because the peaks aren't so high, and also because when you've got the stuff in your stomach, you burp it up. Whereas if it's trapped in the sustained release pill, it doesn't get released into the intestine, so you have less reflux back. Anyway, you can tell in the clinic there's a marked difference in the smell, and most of the patients say that nobody teases them about it. There's still some patients that have halitosis, and it turns out if you give them riboflavin supplements or chlorophyll gum, that helps. But we're learning things, and so the next bit of the talk is things we're learning and things which are cool going ahead in the future. You can overdose patients on cysteamine. There was an Irish group where they figured, well, if a little is good, let's give them as much as they can tolerate. And they started developing all these weird stria, and in places like elbows where there's a little bit of injury, and I have a patient who had these stria up and down his spine from sitting in school on a hard desk. Turned out giving too much cysteamine leads to copper deficiency. Cysteamine has a similar structure to the drugs that are used to deplete heavy metals like penicillamine. And compared to other Fanconi syndrome patients, people on cysteamine with Fanconi's had lower copper levels and lower ceruloplasmin, which is copper binding protein levels. And it turns out that copper is critical in something called lysyl oxidase, which cross-links collagen to give collagen its strength. So that explains why a lot of nephrologists for years have known that if you do a kidney transplant on a cystinosis patient, their scars are pretty. They don't develop keloid. They have nice scars, which after all you can't even see. It's probably because the cysteamine therapy interferes with collagen cross-linking. Women with cystinosis are now living to have children of their own, which is really nice. The males, remember I mentioned the males have testicular dysfunction? No male has ever had a sperm count in an ejaculated specimen. No male until recently had ever had a child. So I have had the experience of talking to a guy who's 18 who'd never heard that he couldn't have children, that he would have the need to be on testosterone therapy because his testicles were going to fail even from the endocrinologic perspective fairly soon. And then just a few months ago, there was a successful fathering of a child. A guy had a testicle biopsy. They found live spermatogonia in the testicle, and it was implanted using in vitro fertilization into eggs from his wife, and they successfully had a child. And the papers in preparation, they did paternity testing afterwards just to confirm, and it's clear that cystinosis males can now father children. So that's been something which has really given a lot of joy to the parents and the young adults to know that that's something that they can do. Cystinosis may be terribly underdiagnosed. Craig Langman was the lead author, and I was a co-author on this study, which was published at the last American Society of Nephrology meeting. We took 4,000 anonymized blood samples from adult dialysis patients through DaVita, and we did DNA testing for cystinosis, and we found 10 patients with a homozygous defect that would be predicted to cause cystinosis. Only one of them actually had the diagnosis of cystinosis on the blood sample. 9 others carried a diagnosis of FSGS, focal segmental glomerulosclerosis, or unknown cause. We can't go back because they're anonymized. So now we have to do another study where we get permission and see if we can find out. But it may be that more subtle forms of cystinosis may set you up for kidney failure, and there may be a huge population of cystinosis out there which aren't diagnosed. If you do a kidney biopsy, the standard way of preparing the kidney for analysis under the microscope dissolves the crystals. So you have to ask for the kidney to be specifically put into EM fixative and then look for crystals, because the regular fixative washes them away. So there may be a lot of people out there. At my own center, we're focusing on bone and muscle strength, and so we've brought in people from across the U.S. and from some South America to put them through a protocol where we're looking at DEXAs, at a lot of detailed muscle studies, and quantitative micro-CT, where we can look at their wrist and their ankle, and we can look right down to individual trabecula, and we can follow the development and growth of the trabecula over time to really understand why these kids have fractures and why the muscles, even in the well-treated patients, are problematic. We're finding weird things, like this is our preliminary data on our DEXA studies. Spines are basically normal. Hips, femoral neck, radius, all low. But look at these two people. They were standard deviation +8. They also had funny teeth. Our hypothesis is they are so polyuric, they're drinking so much water, and they come from an area with a lot of fluoride, that this is fluorosis. This is classic fluorosis. Inappropriately high spine DEXA with normal appendicular skeleton and pockmarked teeth. So we think some of our polyuric patients, because only some of the cystinosis patients in the clinic have this kind of teeth, but we're now testing for fluoride levels in all of the patients, because it may be that the normal amounts of fluoride, which are fine for you and me to drink, are toxic when you're drinking literally 10 gallons a day. This is a picture showing the Mtor Complex, which is critical, which is one of the critical regulators of cellular energy, translation of proteins, DNA damage fixing, and transcription. The Mtor Complex, it turns out, is intimately connected to cystinosin, and cystinosin is essential for mTOR regulation, and there are mutations which separate mTOR interactions from cysteine depletion, and if you have the problem with your mTOR, you get Fanconi's and kidney damage, but there are other mutations where you have problems with your cysteine levels, but mTOR is fine. These people don't have kidney damage, but they have cystinosis, and maybe as an older person they will have kidney damage. So that's cool. There's a whole new area of research. I'm involved right now in setting up the first DNA therapy where there's a cystinosis mouse, and you can take wild-type cells, which are green, fluorescent protein labeled. You put them into the cystinosis mouse, and you can reduce cysteine levels in all the various tissues except for the eye, and you can improve the kidney appearance. So the next step, which we've done, the people in San Diego have done, is they've taken the cystinosis mouse, they've fixed the cystinosis defect with a lentivirus, they've given that back to the same mice after radiating them, and cured the disease. Normal kidney cysteine content, normal kidney function, normal kidney appearance. So the next step is humans. And we're set to do our first 2 human patients by late 2016 or early 2017. And it's the same approach. Take a patient with cystinosis, pull out their stem cells, purify them, send them to UCLA where the defect is going to be fixed, return them, and we're going to do 2 patients to look at the safety, gene frequency, integration, and mutagenesis. So I'm just running through this. Our protocol is set to go. I want to go back one. We're going to do just 2 adults and then watch for at least 6 months to see if there's any surprises. And then we'll do 2 more. We've already picked out these adults. These are people who are allergic to cysteamine, so the ethics balance really nicely. They can't take the drug which will prolong their life, so they're perfect ethically for trying something new like this. So in 10 years, 15 years, this may be standard of care, or it may be back to the drawing board. We keep our fingers crossed. Turns out you don't have to correct all the cells. In the cystinosis mouse, even a small fraction of repaired cells actually rescue cells with cystinosis beside them. In culture and in vivo, the lysosomes actually are shared between cells. So the macrophage is developing these things called tunneling nanotubes, and time-lapse photography shows them developing these little hypodermics which stick into cells in culture next to them. And over time-lapse, you can see the vacuoles moving to and fro along these little hypodermics. So going backwards and forwards, you see them transferring in both directions. So we may only have to get partial repair. Last couple of slides. Average age of diagnosis, 1.4 years. By then, probably kidney failure is inevitable. It's just a question of time. Even with great therapy, there's probably too much damage done by then. So the sooner that cysteine therapy started, the better, or maybe one day gene therapy. It's a rare disease, 1 in 100 to 1 in 200,000 births. And newborn white cell testing, very complex to impossible. There are alternatives that could be tested on the blood spot, cytoheptulose and chitotriosidase, which only reflect a small percentage of the cystinosis patients, so it would not be sensitive. So DNA is the only logical option, but that's expensive. Right now in California, there's 40 diseases that are being screened, and some of them, such as severe combined immunodeficiency, have a frequency of about 1 in 100,000. So they're in the same ballpark. But the state spends $116 per child per test. Now, in Silicon Valley, we've broken the $1,000 genome. When will the whole genome sequencing be in the range of $150? Probably pretty soon. So I expect it won't be too long before all the different chemical testing will give way to genome sequencing on those blood spots. And we may have the ability to treat these patients before kidney disease develops. So the last thing I just wanted to mention was, parents get all sorts of advice. Don't do this, don't do that. This is a kid who's in my clinic now as an adult, and she's so grateful that her parents didn't listen to the doctors all the time. So she had bad rickets, but they wanted her to be normal, so they let her roller skate. And you can see this is a picture from the 80s with a roller rink and the Pac-Man games behind her. And so as people go through life, what I'm learning is there's such an interaction with the parents. And being a partner with them is a privilege, but also it's a lot of work. But hopefully, as pediatricians, you'll embrace this. Thank you for your time. Is there any time for questions? Okay, there's time for questions.
So thank you. That was a great talk. Among the adults who were found to have the genetic mutations for cystinosis, were the mutations different than the usual Caucasian mutation you showed at the start of the...
So there were none of the most common Caucasian 57 kilobase deletion. There were none of that. And I guess you could argue that you're so sick with that it should come to identification, or maybe the person would pass away if it was not diagnosed. These were mutations in promoter regions and also in sites that are less commonly identified that are clearly seen in patients who are diagnosed with cystinosis, but with variable severity of their disease. So we hypothesize that maybe what it is that it may be that you have enough kidney function to get you into your 20s or 30s before your kidneys fail. Or it may be a cofactor. So if you have a higher risk because you're African American and you have ApoA1, or you're born with slightly small kidneys, or you have a few urinary tract infections, it may be an additive cofactor that would be enough to cause florid kidney failure. The overall gene frequency in the dialysis patients of heterozygotes was similar to the background population. So it wasn't like the heterozygotes were enriched for some reason. So we think there's something there. Yeah. Over there.
So with your proposed gene therapy coming up for the two patients, do you think that the type of mutation that they have, mutations that they have, will make a difference in the response to therapy? Or was there, when you were studying the mice, did the type of mutation affect what happened with the mice?
That's a great question. There is only one cystinosis mouse with one defect, so we haven't had the opportunity to explore varieties. So we're hoping that we'll be able to replace the entire gene and have enough of the healthy protein. So whether or not a genetic defect that causes the protein not to be formed or to be formed but not be functional. We think it should work in any situation. I don't have the answer about the genetics of the people that have been selected. They look like your typical Caucasian patients, and I could ask the Stephanie Shirky in San Diego, who's the PI, what the gene sequencing is. It has been done, but I can't give you the answer, though they look like your typical Caucasian. Yeah. Oh, she's running.
I suppose since cystinosin is a transmembrane protein and the dominant mutation is a deletion, there is a possibility of an immune response to the protein introduced by gene therapy?
So theoretically, there's always the possibility. Most of the cystinosin is in the membrane of the lysosome, so it's still protected from the outside world. But class 1 HLA present all of your internal proteins to the immune system for surveillance, because that's the way we find viruses. So there's a possibility of that. Yeah, absolutely. Hopefully, the process of, remember, there's ablation with busulfan. We won't be using radiation, but hopefully there will be enough to set up chimerism that will allow the immune system to live happily. But there is that possibility, yeah. Okay.
So in the mice who you did the BMT or the cell transplant, did you do full myeloablation or modified? Because some of the hereditary metabolic disorders that are treated with stem cell transplant, and probably our BMT people can speak better to this, have modified myeloablative processes?
So a number of different processes were used, but even with modified myeloablations, that did not cause complete wipeout. So there was chimerism when they came back. Over time, the corrected stem cells win. They have better survival. So if you keep watching the animals over time, the corrected stem cells become a larger and larger percent of the population. So it seems that there's a survival advantage to them. In a situation, if there's an immune response, of course, we don't know what's going to happen with that, but it looks promising. And even if there's only partial correction, in the animal model, there are these little nanotubes that go around sharing lysosomes with their neighbors. And so there may be a substantial protection from that. For most people, the kidney disease is inevitable. So stem cell transplantation will not prevent the need for kidney transplantation or dialysis until we have a time when we can diagnose at birth. So advocating for genetic DNA screening for newborn testing at some time when it's available will give us the opportunity to diagnose conditions like this and others at birth and then institute therapy sooner. And that could prevent kidney failure. Okay. Okay, any... Oh, just front row.
Oh.
Well, thanks so much, Paul, for coming. And you've taught me many things. In fact, you've explained why my cystinosis patient whose breath does not smell bad, you've answered the question, are they taking their drug or not? I didn't know that. There's a very evident, very easy method for determining, compliance with drug. But, thanks so much for coming. This is really tremendous. You've done such impressive work. And actually, I hope you'll come back October 1. We're having a World Fair meeting for our lysosomal disease patients. We have that every year over in the McNamara Center across the river. And I hope you mark that off October 1 on your calendar.
So you're asking me in front of a group of people.
That's right.
Someone asking the girl to get married on the Jumbotron at a football game. How do I say no, right? Yeah,
That's
okay.
right. How do you say no? Great. Any other questions? Well, Paul, thanks so much.
Okay, well, it's great to be here. Thank you all.